All right. So let's go and talk about a nerve plexus. And this should look a little bit familiar too, because I mentioned it last class. I believe it was with this section in which I was talking about different structures when we were doing some labeling, and we talked about the cervical plexus, the brachial plexus. All right, there are several plexuses, and I'll try to explain it a little bit to you, but the actual textbook definition is going to be anterior rami. And if you recall, an anterior ramus is that structure that when we have our spinal nerve, well, why explain it when I can show it to you? And I can do both. So you have your spinal nerve that exits out of the intervertebral foramen, and it gives off a small branch that goes posteriorly, and that's called the posterior ramus. But then, all right, we'll see a continuation, what looks to be the spinal nerve, but it's not. It is known as the anterior ramus, or if you're using plural, it's anterior rami. And that is going to be the continuation here of the spinal nerve. Well, what we see, right, with a plexus, it's going to be the interweaving of all these anterior rami that came off the spinal nerves. And it creates this kind of network of branches. And it actually becomes quite beneficial, because when we have these branches that are given off from these anterior rami, if you damage one specific nerve or one of those spinal nerve segments, that, I won't say that's okay, but all is not lost, because you can still get, all right, because it's branched, other rami can still innervate, all right, those regions. For example, if it's muscle, those muscles won't necessarily have a complete flaccid paralysis, right? They might have a little bit of a diminished tone, but in some cases you won't notice anything. Same thing with our dermatomes, right? We might hopefully we won't see any decrease in sensation in any of those dermatomes, and that's because, right, of these plexi, because of those consistent branches that are occurring there. So there's 4 plexes that we will talk about, and there's one on each side. So you have a right and left, right? We have the cervical, the brachial, the lumbar, and the sacral plexus. So you should that should sound familiar to you, because in our last lab section, when we were labeling, we talked about those different plexes throughout the spinal cord when we looked at the longitudinal, excuse me, longitudinal views there. All right, but when we're seeing in the thoracic region, a lot of our thoracic spinal nerves don't form a plexus. In fact, they'll form what's called intercostal nerves, which we'll see about in a second. And also, when we get down to the terminal end of our of the nervous system, of the central nervous system, the spinal cord there, S5 through C1, right, we do not, or coccyx 1, we do not see any plexi formation from those either. All right, so the intercostal nerves. All right, we talked about these. These are the nerves that are going to be located, obviously inter meaning between. We're going to find these nerves in between the ribs, and they are going to be the anterior rami of whatever spinal nerve level that we're going to be talking about specifically, and that'll be, all right, T1 through T11. The 12th, we give a special name, and we call that the subcostal nerve. So when we're talking about the anterior ramus of T1, this anterior ramus is actually going to contribute to our brachial plexus. So it'll give off branch there to the brachial plexus, and we'll get into that in a moment when we talk about the brachial plexus. And then the remaining part is going to occupy our first intercostal space. That'll be the space in between your first and second rib. Our second anterior ramus, right, will be found, right, in the second intercostal space, obviously, but it's going to innervate some of our intercostal muscles. And it's important to know this, it is going to receive sensory input from your armpit, the axilla, and the medial surface of your arm. That's going to be the inside of your arm. So if we go back to our dermatomes here, we zoom in, you can kind of see that a little bit. here is T2. All right, that is going to be the medial portion of your arm and then also the armpit. And then don't forget, all right, especially when we're in the thoracic region, we're dealing with the thoracic anterior rami. I mean, it's a long strip-like section, all right? The dermatome will be pretty much a long strip-like section at these regular intervals here. Thoracic dermatomes are relatively easy. It gets a little goofy when we get in here into the upper extremities, but I'll explain why that is, all right, when we're dealing with the brachial plexus. So it's not too difficult. And you can see it's really easy when we look on the back. Kind of makes sense. It exits from, all right, the T2 intervertebral foramen, and then it just is pretty much going to, the deep ramus will supply this portion of the dermatome. Did I say the deep ramus? Excuse me. The posterior or dorsal ramus will supply the back, whereas the anterior rami are going to supply the lateral portion of your trunk, and then the anterior portion up here in the front. All right, so it's a little bit easier when we're talking about the dermatomes there for the thoracic region. All right, so for T3 through T6, those anterior rami, again, are also going to innervate the intercostal muscles. One of the things I should have mentioned before, when we're talking about, right, our spinal nerves, and you might not recall, right, that those spinal nerves are mixed nerves, which means they have sensory neurons and they have motor neurons. Right, so that means that a sensory nerve, a spinal nerve is going to receive sensory innervation from the skin, and it's also going to provide motor output, right, to specific muscles, so that you'll see that kind of double-edged or that two-way street there. When we're dealing with our spinal nerves, they're going to have a sensory component, all right, and they'll have a motor component. So that's why when I say, right, innervates intercostal muscles, that's the motor component. And then when we're dealing with the sensory component, now we're going to be talking about, all right, that sensory input that's coming from those dermatomes along a specific region. So again, you can go and take a peek at the dermatomes here, but again, T3 through T6 is going to receive, like I said, that anterior sensory input from the anterior portion of your chest and the lateral portion of your chest, because the posterior portion is going to come through the dorsal rami. All right, and then T7 through T12, right, will also affect the intercostal muscles. And now, since we're getting closer down to the abdominal region, we'll include some of the abdominal muscles there. And then we'll get sensory input from those, again, those dermatomal regions there in the skin throughout the thoracic region and the abdominal region there. So that's basically what we're looking at here. When we're looking at our intercostal nerves coming off, zoom in here a little bit. So here's our spinal nerve. Then it gives off the posterior ramus, and that goes off to innervate the deep muscles of the back and the skin back here. And then the remaining portion is the anterior ramus. So that swings around here to the side. And it gives off some branches to innervate, all right, the sensory dermatomes here on the lateral region. And then we swing around to the front, and then we'll see the intercostal nerves, of course, giving off branches. That's also going to give sensory innervation to the anterior portion. And then, of course, it's going, depending on which rami that we're talking about, is going to affect either intercostal muscles or some of the abdominal muscles and the intercostal muscles, depending on what ramus we're talking about. All right, so let's talk about our cervical plexus, our first of 4 plexes. All right, the cervical plexus is going to be made up of, again, remember, plexes are made up of anterior rami of C1 through C4. Now, C5 gives a few contributions, all right, but it's not really worth noting. And again, some of this varies. And some people walking around on this planet, C5 gives no contribution, right? And you might see another spinal segment that gives a fluke contribution like C6, all right? I'm not saying it's not an impossibility here. All right, so for the cervical plexes here, the branches that come off the cervical plexes, all right, are going to innervate the anterior muscles of your neck. That will include some of the smaller muscles there, right, when we're, excuse me, dealing with pharyngeal muscles, right, We'll also see like the platysma. All right. Also, it will provide dermal innervation of the neck. And then certain parts of the head and shoulders. Remember, we're not going to see the cervical plexes offer any innervation for sensory input from the face. All right. And there's a reason for that. Does anybody happen to know what innervates the face for sensory input? I'll give you a hint. It is not a spinal nerve. Remember, there's two types of nerves that we deal with, spinal nerves, and the other type of nerve that comes off the brain is called cranial nerve. It's one of your 12 cranial nerves. Does anyone recall? No worries, no worries. It is cranial nerve number 5, trigeminal. You should know that. Okay, the sensory innervation to your face comes from cranial nerve 5, which is trigeminal nerve. There's 3 branches or divisions of cranial nerve 5, the ophthalmic, the maxillary, and then of course your mandibular. Okay. One nerve of note that comes off of the cervical plexes, right, C3 through C5, so that means C3, C4, C5 spinal nerves, all right, will contribute to this guy, the phrenic nerve, which innervates our breathing muscle, the diaphragm. How I remembered it, C3, C4, C5 keeps your diaphragm alive. So if you damage the phrenic nerve, you will have some difficulty innervating the diaphragm. And it's interesting because, all right, sometimes if the phrenic nerve is irritated, it can give you hiccups. Okay, those hiccups, right, will be a result of that diaphragm, all right, malfunctioning and causing that sensation there. All right, when we look here at our cervical plexes, let me zoom in. All right, so here you can see C3, C4, C5, some branches here that are coming off here of each of the anterior rami, and they start to form the cervical plexes here. And then we'll eventually see how some of these branches from C3, C4, and C5 help to form the phrenic nerve. And now there's a lot of other structures here like the ansa cervicalis and all these different, don't worry about that for right now, just know, all right, the phrenic nerve. There's just not enough time to memorize all those other nerves that come off of that region there. All right, that's the cervical plexus. Let's talk about the brachial plexus. Right? Without saying from here on out, I'm not going to mention the fact that, all right, a plexus is made up of the anterior rami. I'm going to assume that you know that. I'm just going to point out, all right, what spinal segments. C5, C6, C7, C8, because there are 8 cervical spinal nerves. There's only 7 cervical vertebrae, bones. Right? There's 1 more spinal nerve than there are vertebrae. So C5, C6, C7, C8, and T1. So we're going to see these fibers coming out from the side of your neck. And they'll come out of the side of your neck and then go down into your armpit, into the axilla. And so we'll see here, we start off with the anterior rami. And then as we move through the brachial plexus, we start to create different parts or divisions of the brachial plexus. We go from the anterior rami to the trunks, to the divisions, to the cords, and then eventually the nerves that will come off, right, and go out to the distal portion of your upper extremity. So what we're going to see is these anterior rami from C5 through T1 are going to form these structures called trunks. And this is going to be in a region called the posterior triangle of the neck. Now, granted, this is on the lateral portion of your neck, but it's going to be more towards the posterior region. And so you have the anterior triangle and you have a posterior triangle. right? This is located in the posterior triangle, but it forms these three trunks, the superior, middle, and inferior trunk. For the most part, when we're looking at the superior trunk, contributions come from C5 and C6. The middle trunk is only one segment, is C7, and then the inferior trunk will be C8 and T1. And then we'll see these trunks will divide into anterior and posterior division. I know it gets complicated here, right? I just want to kind of give you a general overview here. And so these anterior and posterior divisions are where we're going to start to see, all right, these portions, these branches of nerves, which are going to innervate the front of your upper extremity and the back of your upper extremity. So from those divisions then, all right, we are going to form, all right, what we call the cords. This occurs in the axillary artery. The axillary artery is pretty much what we call the artery that runs down your arm, all right, when it is in the axilla. It'll change names, and then we'll start calling it the brachial artery when it starts to actually get into the brachial portion of your upper extremity. It has another name when it's located in close proximity to your collarbone, to the clavicle. We call it the subclavian artery. And so we just call it, we change its name of this artery as it's moving through, all right, your thoracic area, the axillary area, and then into the upper extremity. So here, all right, where the axillary artery is located, this portion of the brachial plexus, right, we'll have our three cords here, the posterior cord, the medial cord, and the lateral cord. Now, this is important, right, because we're going to start to really get into some of the other nerves here in a moment. But we'll see, right, the posterior cord is going to contain all of the spinal cord segments, right? Whereas the medial cord, right, which is going to come off of the anterior division, all right, it only has the lower two segments, C8 and T1, whereas our lateral cord is going to be made up of the anterior divisions, and that is going to be made up of the upper portions of our spinal segments here. That'll be C5, C6, and C7. So this is really where I kind of wanted to get into, all right, because, yeah, you know, the brachial plexus, let me see if I got a picture here. Right, here you can see the brachial plexus and how it's all divided. Okay, so here we have our anterior rami in close proximity to the spinal cord. So they'll start to contribute branches, and then the second portion of our brachial plexus is going to be our trunks. Now, again, it's pretty easy to see the trunks here because obviously the superior trunk is going to be closest to the head, and obviously the inferior trunk is going to be closest down toward your feet. So that part is easy, but it's tough to see when we get into the divisions here, right? Because there's really nothing else where we can see the relation of where things are traveling, right? But the next part is going to be our divisions, and you'll notice how, right, we're going to form the anterior divisions from C5, C6, C7 here. Our posterior division gets contributions from all of our spinal cord segments. And then, of course, our, where am I? Oh, I jumped ahead. Where am I? Okay, yeah. So our anterior divisions are going to come off the C5, C6, 7, and then our posterior divisions, that's going to get contributions from all the different segments here. And then finally, not finally, we get into the cords here, and that's going to receive, all right, branches from the upper, all right, when we're looking here at the, in the lateral cord here, we'll see you'll get the divisions from the upper portion of the brachial plexus. Our middle here, or the posterior cord, is going to get contributions from all of them. And then down here, the medial cord is going to get contributions primarily from C8 and T1. And then that's what gives us our terminal branches. That's what I wanted to get into. That's more important for what I want to talk about today. Right? The 5 different terminal branches, you should be familiar with these, and you should be familiar with what muscles they innervate and what sensory input that they provide to specific areas of your upper extremity. So let's start off with the axillary nerve. Axillary nerve is going to innervate your deltoid and the teres major muscle. That's going to contribute primarily to abduction, right? But we'll see on the superior lateral portion of your arm, which is this area here, that's where you're going to get the sensory input from the axillary nerve. All right, the median nerve, this is the nerve that is going to be compromised during carpal tunnel because it travels through the carpal tunnel, all right, near the palm of your hand. So the median nerve is going to control, all right, the flexor compartment muscles. That's going to be the muscles on the interior portion of your forearm, the muscles of your thumb, okay, the thenar muscles, that pad that's there at the base of your thumb, the lumbricals, which are the muscles in between your fingers, and then it's going to provide sensory input, right, on the palm of your hand, that's going to be the front of your hand, and the tips, right, of most of your fingers except the pinky. The pinky gets innervated by the ulnar nerve. Musculocutaneous, this is going to be the flexor muscles of your arm. Example, the biceps brachii, brachialis, coracal brachialis, right? The musculocutaneous nerve will innervate those flexor arm muscles there, and then it will also give you lateral, all right, sensory innervation of the forearm. Radial nerve, posterior arm muscles, so those will be the arm extenders, right? The triceps brachii muscle group. And then we're also going to see the posterior forearm muscles, which are the muscles of extension. So the radial nerve is going to provide sensory input from the back portion of your arm. Okay, easy to remember because that's where the triceps brachii are. Right, the posterior portion of your forearm, and then on the back side of your hand and the lateral portion of your hand. Then finally, the ulnar nerve is going to innervate some of your anterior forearm muscles. That'll again be your flexor compartment. And then we'll see it in the deep intrinsic muscles of your hand, right, for flexion, extension, abduction, adduction there. And then also it's going to provide sensory input on the medial portion of your palm and also on the back side of your last two fingers, digits 4 and 5. All right, so you can see all these nerves. Let's get rid of this. Okay, so down at this point here, when we're in your upper extremity, you have the terminal branches, all right, off the brachial plexus in this region right around the axilla here that are going to form, all right, those 5 different nerves that I was telling you about. Think of it like this. The ulnar nerve travels on the inside of your arm. Well, guess what? The ulnar bone of your forearm, when you're in the anatomical position, is on the medial portion of your arm. Okay, on the inside. So the ulnar is on the inside. The radial nerve travels on the lateral portion. Well, the radius is on the lateral portion. Then we'll see the median nerve. That's going to travel pretty much down the front of your arm here through the cubital fossa of your elbow. And it travels right here, all right, through your carpal tunnel. And it can get pinched there, but it is going to offer a lot of innervation for the palm of your hand on the anterior portion here and the tips of the fingers here, except for the pinky. Musculocutaneous nerve, right? That's going to be up here on the near the front of the anterior portion of your humerus. That's going to affect the muscles here. And then you have your axillary nerve right here, which is found, interestingly enough, around the surgical neck of the humerus. So you have to be careful because if you damage the cervical, did I say cervical? Excuse me, the surgical neck of the humerus, you are at risk of damaging the axillary nerve. And if someone ever severs that nerve, they will have a significant amount of difficulty or abducting their shoulder, and they'll have some deficiency of sensation right around this region here. Okay, let's move on to our third plexus, the lumbar plexus. Right, it's getting its contributions from L1, L2, L3, and L4. The lumbar plexus is going to form the femoral nerve. That femoral nerve comes off the posterior division of that plexus there. And that's going to innervate the muscles that straighten your knee. So that's going to be your anterior thigh muscles, your quadriceps. And remember sartorius, that's that long strap-like muscle that crosses over the front of your thigh and then will insert itself on the medial aspect of your knee there. The sensory input for the femoral nerve is going to be again on the front of your thigh, but also on the inside, but the inferior portion of the inside of your thigh, and also on the medial portion of your leg, the inside of the leg there. Obturator nerve is another nerve that comes off of our plexus. It comes off of the anterior division of the plexus. So it's going to innervate your abductors, or the medial thigh muscles here. Sensory input comes, all right, into the inside of your thigh, but in the superior portion. Okay, so here you can see our lumbar plexus here. Again, you can see the contributions from the spinal segments here of L1, L2, L3, and L4, and then it creates an anterior divisions and posterior divisions. Off of the anterior division here, you're going to get the obturator nerve. Off of the posterior division, you're going to get the femoral nerve. Those are the big ones. Right, so as we move in, let me zoom in here on our lower extremity. Okay, femoral nerve, remember the femoral vein, artery, and nerve, right? It's going to be more on the medial portion of your thigh, so you can see it coming in, and then it branches out to innervate these anterior thigh muscles. Also, for the sensory innervation, the medial portion of your leg, and then up here, it's going to innervate the inferior portion here in the inside of your thigh. Whereas obturator, you can see it poking out here through the obturator foramen, right? It comes out and it's going to give sensory innervation to the superior medial portion of the thigh, but also it's going to innervate the thigh AB abductors. And then finally, our last plexi, right, is the sacral plexus, and that is going to get contributions from L4, L5, S1, S2, S3, S4. And so again, we're going to create, right, anterior divisions and posterior divisions. Our anterior divisions are going to innervate the flexor muscles for our lower extremity. The posterior division is going to innervate the extensor muscles. So of course, I have to talk about this nerve here, which is the largest, longest nerve in the body, the sciatic nerve. Right, this nerve emerges, all right, from your pelvis there, posteriorly, all right, just below the piriformis muscle, and it's going to run down the back of your thigh. All right, it is made up of both, all right, divisions, anterior and posterior portions of the sacral plexus there. And so it's going to travel down the back of your thigh and head towards the knee. Right, and eventually it's going to divide into the tibial division and the common fibular division. Sometimes it is referred to as the common peroneal division. All right, but regardless, this nerve will eventually split off. And this usually occurs around the popliteal fossa, which is that area right behind your knee. So just before it hits that area, it splits off. So we'll talk about those. So we have got our tibial nerve and the common fibular or common peroneal nerve. So the tibial nerve is the anterior divisions that came from the sciatic. So it is going to innervate your hamstring muscles, which is going to be a hip extensor group and a knee flexor group. And we'll also see part of the adductor magnus muscle. Now, when we talk about the sensory innervation, right, this nerve is going to give sensory input, all right, from the bottom of your foot on the sole there. So the tibial nerve, all right, as it's traveling, all right, in the superior portion of your leg, that's going to be just below your knee, it splits off. And it splits off into the lateral and medial plantar nerves. All right, and those will innervate various muscles, all right, on the plantar surface of your foot. The common fibular nerve, all right, is made up of the posterior division there. And so it's going to innervate, all right, the short head of the biceps femoris muscle. And as you know, that is one of your hamstring muscles. It's located laterally. And then this nerve splits off into the deep fibular nerve and the superficial fibular nerve. And our deep fibular nerve is going to control the anterior leg muscles. And those anterior leg muscles are on your shin. And so they are going to cause inversion of the foot and also dorsiflexion. They'll lift your foot up towards the ceiling there. And some of the smaller muscles on the top of your foot, which is also known as the dorsum. It gets its sensory input from, again, the top of your foot. But here's the thing, from a small patch of skin between your first and second toe. I don't have a good, nope, I don't have a picture of a toe where I would show you exactly where it is. So you'll see, all right, where your first and second toe meet your actual foot, right? It's a small circular area there. I got to show it to you. So here's your big toe with your toenail. And then here's your second toe. And so where the two join together right here, it's going to be this patch of skin right around that area there. All right, then finally, the other nerve that divides off is the superficial fibular nerve. All right, and so this is going to innervate the lateral compartment muscles, which is going to be your the fibularis longus or peroneus longus and brevis. Okay, so it'll be those two muscles there on the lateral compartment, and then it receives its sensory input from the actual top portion of the whole foot there, and then also on the bottom portion of the front part of your shin there, the anterior inferior portion of your leg. So here you can see the sacral plexus, and again, you're going to form, okay, posterior and anterior divisions, but when we're talking about the main nerve that comes off, that's our sciatic nerve, and then that sciatic nerve will split into the common fibular nerve and the tibial nerve, all right around your knee, just above your knee there. So in case you were wondering where all those nerves were, let's take a little trip here. Here comes the sciatic nerve going down the posterior portion of your leg. It then splits off into the common fibular nerve that heads off towards the fibular head. And sometimes you'll see, all right, right along the neck here of the fibula, if you fracture that, you are in danger of damaging this nerve. And when that happens, then you are going to lose innervation here, right, to the muscles in the lateral compartment. You're going to have some issues on the dorsum of the foot with nerve sensation reduction. All right. You'll also see here, okay, as the sciatic nerve bifurcates and splits off, the tibial nerve comes down towards the bottom of the foot, and then it'll split off into the medial and lateral plantar nerves, which will give innervation for the bottom of your foot. All right. like I said, I know it's not the most interesting stuff, but regardless, we had to go over it. So let's go ahead and look over the last portion of our slides for the spinal cord. Let me just pull those up. There we go. All right. Where are you? Okay, so let's go ahead and pull those up real fast. Go over various sections here to our spinal cord. All right, so these are transverse cuts. So I'm going to show you a couple of structures here that I really want you to become familiar with. So, because for those of you that might go into, like, say, anesthesiology, it's important that you understand this, because if you were ever to do an epidural, if you were to do a spinal tap, you need to know where you're going to go when you are providing these types of critical and important procedures. Plus, you're messing around near the central nervous system, so you got to be careful. All right, so of course, we know that the outer portion here of when we're talking about the spinal cord, for the coverings of the spinal cord, are going to be the bones, the vertebra. And the vertebra are covered by periosteum. That's what this dark blue is supposed to be representing. Okay, so that's going to be the periosteum here. So we're just going to work our way inwards and show you the different layers of structures as we proceed towards the spinal cord. So the first is going to be the bone. The periosteum is the covering to that bone. Then we go a little bit deeper, and we are actually in the epidural space. Well, it's just not an empty space. It's filled with fat. So we call that the epidural fat. You'll notice there's quite a bit of blood vessels here. This is a great place to give drugs to people, okay? Especially, you got to give an epidural, right? Adipose tissue is highly vascularized. You can see tons of blood vessels here in our model. So if we bring a needle in and inject anesthesia into this area here, it's going to be quickly absorbed and distributed all throughout. Wonderful place so we can get a good numbing effect for patients. So this is the area where we're going to give our epidural injection. Let's go deeper. All right, our next layer is the Dura Mater, the outermost layer to our meninges. The Dura Mater is the thicker, all right, layer. It is very protective, helps to do a lot of support for some of the neurological structures. So that's the outer layer of the meninges. We go deep to that. This next gray line here is the Arachnoid Mater. All right, that's our spidery mother. All right, then you'll notice just deep to that is the subarachnoid space. Again, a very important area, because the subarachnoid space is, again, not an empty space. It's filled with our cerebral spinal fluid. So if you need to do a spinal tap on somebody because you suspect maybe, I don't know, meningitis, God forbid if it's bacterial meningitis, all right, that's a pretty rough one. All right, so we've got to get our needle into this space. So we got to go in between the bones. And there's some ligaments that hold these bones together. So we got to pierce through those ligaments. Then we got to push our way through our epidural fat here into the epidural space, through the Dura Mater, through the Arachnoid Mater, and then into this space here where your cerebral spinal fluid is located. We don't want to go much further, because then we can poke into the Pia Mater and hopefully not into the spinal cord itself. All right, so we've got to, it's a very delicate procedure, all right, but that's where we have to go if we want to capture some of that cerebral spinal fluid. And then, of course, our deepest layer here is the Pia Mater. The Pia Mater is made up of that very thin tissue that layers or lines right on top of the spinal cord. You'll notice it goes right in through this area here. So it adheres directly onto the spinal cord itself. And that's the Pia Mater. All right, so our spinal cord is made up of, all right, white and gray matter. Now we're just going to review and kind of hammer home where these specific structures are labeled in what they are. All right, so here's the white matter, then you can see the gray matter, even though it looks brown in this model, all right, which is deep to that. So here I'm going to go back and forth between two different models. Okay, so here's the white matter on our other model. All right, so in the back portion here, remember we call it the posterior funiculus. All right, well, in lecture, this is the posterior white column back here. All right, posterior white column is going to be in the posterior region of our spinal cord. We're going to be dealing with mainly sensory information in that region. Here you can see the posterior white column here. All right, then you can see on the side here what we would call the lateral funiculus. That's the lateral white column here on the side. There's a mixture of sensory and motor tracts that run in that area. That's the lateral white column. Here's the other lateral white column here. Now you notice there's a little bit of differences between these two models, which is good. You need to get some different perspectives on some of these models here. And then of course, right in the front is going to be the anterior white column. All right, anterior white column. And again, when we're talking about white column or gray, whatever, keep in mind what that tissue is made up of, right? If it's white, it's myelinated axons. That's simple. If it's gray, well, it's going to be made up of cell bodies, unmyelinated axons, some dendrites there, even some glial cells. Right? So you're going to see just a couple different structures here. Right, and there's the anterior white column. I don't know why I called it whiter column. But anyways, I got to change that. You know me, folks, this is going to bother me. There we go. All right, anterior white column. All right, now let's get into the gray matter here. All right, so the back portion here of the spinal cord, that's where that sensory information is going to come into. That is known as the dorsal, or you can call it the posterior gray horn. Okay, dorsal gray horn or posterior gray horn, either or. All right, here you can see it on this model. That's the dorsal gray horn or the posterior gray horn. Again, it's just gray matter. All right, now you can see, right, as we move further anteriorly, here's the lateral gray horn. The lateral gray horn is going to contain the cell bodies of our preganglionic neurons when we're talking about our autonomic, specifically the sympathetic division of the autonomic nervous system there. You're going to see those cell bodies found at T1 all the way down to L2. All right, the lateral gray horn. So that's going to contain autonomic cell body preganglionic neuron. Here's the lateral gray horn on this model. All right, and then finally, not finally, but looking at the gray matter here, all right, we have our ventral gray horn or the anterior gray horn. The anterior gray horn contains the cell bodies of the somatic motor neurons, right? The lower motor neurons from the somatic nervous system. So it's going to be carrying voluntary motor commands out to the skeletal muscle. Whereas the lateral gray horn will carry our involuntary or our motor command information from the autonomic nervous system out to the effectors, which are going to be cardiac muscle, smooth muscle, or glands. And then here you can see the ventral gray horn, anterior gray horn on this model. Okay. So in the center of our spinal cord, we have the central canal lined with the ependymal cells, which will be producing cerebrospinal fluid. You will find cerebrospinal fluid in our central canal. You can see it's right in the center there of our gray matter. And then you can see the central canal here on this model. All right, and then we have our gray commissure. Remember, commissural fibers cross over the midline. So in this case, the gray commissure contains unmyelinated axons that are going to cross from the left side of the body to the right side of the body and vice versa. That is the gray commissure. And here you can see it in this model here. And then you'll notice there's going to be, it looks like where one side of the spinal cord and the other side of the spinal cord kind of push their way in. And there's a fissure here. So we refer to that as the anterior, not anterior median fissure, not medial. Okay, median means it's dead center. This is directly in the middle. This is the anterior median fissure. Show it to you here. Again, it's the anterior median fissure. So that's on the front side. On the back side, we have the posterior median sulcus. You'll notice we have the Pia Mater invaginating on both sides pretty much interiorly. You don't see that going on here in the posterior median sulcus there. Here you can see it on the back side there, the posterior median sulcus. So fissure in the front, that's how I always remembered it. Fissures in the front, sulcus is in the back. All right, so as you recall, our spinal nerve, right, is going to be located somewhere in the intervertebral foramen, and it's a mixed nerve, and it receives, all right, both sensory neurons and motor neurons, all right? But before we get to that spinal nerve, you have this swelling here on the posterior portion, all right, of this region. And that's our posterior root ganglion, or also known as the dorsal root ganglion. This is the location of those cell bodies for those first order or those primary neurons that are coming out from the receptors located in the periphery towards the spinal cord. So the cell bodies for those neurons will be located in our posterior root ganglion. You know what also resides in the posterior root ganglia? Chickenpox virus, the varicella zoster virus, when it lies dormant. When it goes to sleep, it'll stay here, waiting, trying to get you. I like this model better because it shows the dorsal root, posterior root ganglion just a little bit better, easy to see. Posterior dorsal root ganglia. Right now you can see, we zoom in here on the spinal nerve. This is our mixed nerve. Also, we're in the intervertebral foramen. Spinal nerve exits out of your vertebral canal through the intervertebral foramen. You can see a little bit better on this model here. Spinal nerve, mixed nerve. Should know that. Should be second nature to you. All right, spinal nerve. Then you'll notice as we zoom in here close to the spinal cord itself, you see these little strands here, these little yellow strands. Well, that contains the sensory neurons. So we can call those either the dorsal root of the spinal nerve or the sensory root of the spinal nerve, also known as the posterior root. So there's three different things that you can call it: the dorsal root of the spinal nerve, the posterior root of the spinal nerve, or the sensory root of the spinal nerve. It contains sensory axons, sensory input coming into our spinal cord. Here you can see all that structure right there, the dorsal root of the spinal nerve, posterior root. Sensory goes into the back. Well, that was on the front. Now that was on the back. Now we're on the front. And so you can see here, we have our ventral root, also known as the anterior root of the spinal nerve. You can call it the motor root also. And that's going to contain the motor axons that are traveling out to the effectors. So there you have it, the ventral root of the spinal nerve, also known as the anterior root, or you can refer to it as the motor root. Okay, so as our spinal nerve exits out of the intervertebral foramen, it gives a branch that goes immediately posterior toward your back. That branch that is coming off is known as the dorsal ramus. Right? You've heard me refer to it as the posterior ramus. All right, dorsal ramus or posterior ramus, and again, that is going to go towards your back and control the deep muscles of your back, and also sensory innervation to the posterior skin of your back. Then the spinal nerve continues on as the ventral ramus or the anterior ramus. And that'll go on to do various things. Innervate muscles located all throughout the thoracic region, the abdominal pelvic region, sensory innervations through the dermatomal regions of the lateral and anterior portion of your trunk, in both your upper and lower extremities. It will also contribute to the sensory innervation of those areas too. That's the ventral or anterior ramus. This here is showing you one of the rami communicantes. Right? You will not be held to the specifics, whether it's the gray or the white. So you can either call it the ramus communicans or the rami communicantes. And basically, that is how we connect your spinal nerve to your sympathetic trunk. That's what this is attaching to. Here's your sympathetic trunk. All right, sympathetic chain or the sympathetic trunk. Now, if it was a fat structure on the sympathetic chain or trunk, you would call it the sympathetic ganglion, but this is not. This is only part of this dissection here is showing you the sympathetic trunk only. Okay, everybody, that concludes those slides there. Do you folks